Alright, welcome back. So last time we were in reproductive anatomy. We just started. We went through the key blood vessels and stuff. I did add something brand new here compared to the last video. Put in two little images here to show you some big time pathologies that you can get a question on, and it might present in a manner that you might not know, what's happening. So, venous drainage was a pretty big deal yesterday, right? Especially on the left side. So you can see over here for the veins and the arteries. So the arterial stuff is pretty straightforward. The gonadal arteries come straight out of the aorta, right? So you can see it's right above the inferior mesenteric artery. They just go ahead and go straight to the gonads, whichever one it might be, whether it's testicular or ovarian. The venous drainage, however, on the left, it's weird, right? So on the left, you can see here, this is the testicular stuff. It's the same for the ovarian. The testicular or the gonadal veins on the left side drain into the left renal vein, right? And then they drain into the inferior vena cava. So that gives space for pathology, because you can see this is like a 90-degree angle here, so flow isn't exactly that good either. And if the patient has renal issues, that further increases the chances of having an issue there. Now, there were two syndromes here. So there's Nutcracker syndrome, and then there's the May-Turner syndrome. Most of you have probably already heard of the Nutcracker syndrome, which looks like this image. So you can see here how the superior mesenteric artery, which is above here, the superior mesenteric artery is kind of squeezing onto the left renal vein, right? And if it's squeezing onto the left renal vein, then that's going to be a problem, because now blood is kind of backing up, and that can present in many ways with pain and renal failure and stuff like that. Right, so that's your renal nutcracker syndrome. And then here, this is May-Turner syndrome. This is the only other possible thing you can really expect to see on step 1. I wouldn't even expect to see it really, but they can kind of throw it at you. So what happens in this is that you can see, I described it right here, and there's the picture for it. This is caused when the left iliac vein, which is really engorged here, the left iliac vein, the blue one in the back, is compressed by the right iliac artery, right? So the right iliac artery is squeezing onto the left iliac vein, okay? The left artery is sitting on top of the left iliac vein, so the left artery is not the one doing anything, but it's the right celiac artery that's kind of squeezing the left iliac vein. And this is usually seen in women. The Nutcracker syndrome is more often seen in men. This one is seen more often in women, and it's usually just going to cause all this blood in the left iliac vein to back up, causing engorgement of blood vessels on the left leg, and definitely increasing the risk of a DVT in the left leg, right? So deep vein thrombosis. And other than that, there was a bunch of lymphatic stuff you really needed to know, very high yield stuff. This would be a good time to go back to immunology and revise some more lymphatic drainage from the first section of immunology as well. And you get very straightforward questions, which we tried to look at yesterday, and it wasn't so bad. We also looked at the female reproductive anatomy, and that was good to go. We came down to here, looked at all the different, ligaments you need to know and how to memorize them, right? Where your mesosalpinx, right, connects the fallopian tube and comes downwards towards the ovary. Mesovarium is on the ovary, and then your the last one. Where's the meso? They don't have it in this picture, because there's 3 of them, right? So remember this right here. Mesometrium is the last one, right? They're all part of the broad ligament. Okay, so in this image, they just called it the broad ligament of the uterus here, but this is your mesometrium. Okay, so that's the one they've labeled as just the broad ligament, but the broad ligament really encompasses all 3 of them. Okay, and on this side, you're seeing blood vessels, right? And there was a big deal here. There was a UWorld question regarding, after delivery, if the mother is not stopping bleeding, what arteries are you supposed to ligate to stop the bleeding, but at the same time keep the ovaries alive? Right, so you can see how blood supply to the ovaries comes separately, right? There's this ovarian artery coming separately, and remember, your ovarian artery came straight off of the aorta, right? That's going to keep your ovaries alive. But if a mother is bleeding, she has a lot of intrauterine bleeding after delivery, you're supposed to ligate the iliac stuff, right? So anything right here, these uterine vessels coming off the internal iliac artery, you can ligate that, and it'll stop blood supply to the uterus, and you can prevent bleeding there. All right, we had a question on that right up here, right? This one right here, right? to bilateral ligation of which artery will control her bleeding and preserve her fertility, aka preserve her ovarian artery. So that was the internal iliac. That was a UWorld question. These images, this one over here on the left and right, these are images from Amboss, kind of giving you the breakdown of the anatomy in a very straightforward, nice manner. Okay, the round ligament of the uterus, remember, was significant because the round ligament came all the way out to the labia majora, right? Connects there, and because of that, during pregnancy, many women will complain about pain, and it's just normal pain. This is normal pain that just occurs. There's nothing to be worried about. So that was all the stuff we did yesterday, and then we were up to female reproductive epithelial histology, right? So this is where we stopped, and then we're going to jump into male reproductive anatomy. So we didn't get a chance to look at this note from Amboss, but before I go into that, let's actually learn this first. Now, this is not so hard. This is one of the tiny things that you're going to look at once and never revisit again, right? There's a couple times I've said that in this playlist. There are a few, very few things throughout first aid which you just look at once, you learn it on that day, and then you never need to quote-unquote revise it again. You have to make solid memory of it the first time you study it and just get it down because it's one of those things that's just not that complicated. And so all of this is going from outside to inside, okay, from up to down. This is from outside to inside. So vulva, vagina, ectocervix, which is outside. Then you have this transformation zone, which is very high yield. Then now you're inside, so the endocervix, the uterus, the fallopian tubes, all the way to the ovary, right? So this is all histology stuff now. So you can see on the outside, right? On the outside, most of the stuff is stratified squamous, and that makes sense, right? Because things outside, like your skin and any other part of your skin, or like the dermis and epidermis, all of this outside stuff often gets rubbed and damaged and slows off, and then you have to make new stuff. So stratified squamous is a good way to go. So the upper layer can rub off and you can make new layers, right? So that's a really easy way to understand and remember that the vulva, vagina, and ectocervix must have stratified squamous epithelium. And it definitely cannot be it definitely cannot be keratinized. So it's all going to be non-keratinized, because if it was keratinized, it'd be very, very dry, right? So this is all non-keratinized stuff, the vagina and the ectocervix. Now, inside the endocervix and the uterus and the fallopian tube, these guys have simple columnar epithelium, okay? And that makes sense too, because these guys have a lot to do. Think of them as the guys that are kind of responsible for making sure that menstruation kind of happens, right? Things are going to be delivered by the fallopian tube, and depending on, how whether or not the patient is trying to get pregnant, there will not be sperm there, but either way, all of these guys are there to kind of help prepare the uterus to go ahead and menstruate. So I like to think about all of that as a very secretory thing, right? There's a lot of secretions coming out, and columnar cells are very much good at secreting things, especially in the GIT when we looked at histology and stuff. In GIT, any part that needed to secrete a lot of mucus was usually pretty columnar. Right? There's no reason for the endocervix and the uterus and fallopian tube to have stratified squamous epithelium. This is really about stuff that's in contact with regular friction every day outside on your body. So these guys are columnar. Now, because of that, there's a transformation zone, of course, where as you go from the ectocervix to the endocervix, at some point, your stratified squamous epithelium becomes simple columnar epithelium. And this transformation zone is very high yield because it's the most common area for cervical cancer, right? So this is why when you do a pap smear, you check the cervical area, right? You take a pap smear of the cervical area, and if there is anything wrong here, anything pathological, then you go ahead and try to do more diagnosis, do more investigation, and figure out, not do more diagnosis, do more investigation to figure out a diagnosis, okay? So I wrote over here, right? The outer portions are squamous because they shed often due to sex and bathing, okay? The inner portions are columnar to secrete mucus, right? Because everything inside has to be really nice and moist. And then things get a little different at the ovary. So your ovary, right? The outer surface of your ovary is all simple cuboidal epithelium, all right? So over here I wrote, remember that the transformation zone has squamo-columnar epithelium. So before that, it's all squamous, and everything after that, it's all columnar. That's another way to remember it, if you just remember squamo-columnar being a big deal. The ovary is the only one with simple cuboidal epithelium, and the cells divide and proliferate rapidly to repair the ovarian surface defects from ovulation. Remember that your ovary, right? Your ovary during ovulation, your ovary literally erupts, right? A tiny portion is just gonna pop open, and then the egg comes out, and that tiny portion that just ripped open from the ovary has to be repaired, and it's because of that that they chose, or your body chose to have simple cuboidal epithelium there, right? Really easy to just regenerate and fix, rather than using stratified squamous, which is really preferred for outside stuff, and definitely not columnar because those are tall cells. Those are a little harder to replace than simple cuboidal cells. Okay, so if you ever get questions on any of this, it's usually going to present in either this manner or something regarding the cervical area. The question up here says a 33-year-old newly-gravid woman comes to the office for evaluation of infertility. She has never been pregnant despite years of unprotected intercourse with her husband. She also has pelvic pain, which worsens with menses. The pain has persisted despite medical therapy and is suspected to be due to endometriosis. Laparoscopy is performed and multiple flesh-colored nodules are present on the pelvic organs, along with thin, firmy adhesions. In addition to having endometrial glands with hemosiderin pigment, one biopsy contains simple cuboidal epithelial cells. What is the most likely site of that biopsy? Right? And that's straight up just asking you, like, you don't even need to care about this entire clinical scenario. They just wanted to know the most likely site of this cuboidal epithelium, and it has to be from the ovary. Right? The ovary is the only part of the female reproductive epithelial histology with simple cuboidal cells because it breaks and heals monthly. Right? So if you've never seen what this breaking I'm talking about is, you could probably find a very easy YouTube video showing rupture of the ovary to release an egg. Right? And it's literally a rupture. Like the ovary is nice and round, and then a small portion just rips open and the egg comes out, and then that ripped open place has to be closed again. Right? So if you look at an ovary of a much older woman who's near menopause, you'll see it's got a lot of tiny ruptures that have been healed all over the ovary, because that's kind of what it goes through. Right? The more times you have eggs being released, which is obviously once a month, the more times it gets messed up. Right? And also keep in mind that they alternate, right? Once is this ovary, the other time is the other ovary. So if a woman has gone through 40 menstruations, it's probably 20 from this one and 20 from the other one, right? Don't mess that up and think it's all 40 from the same one. Now up here I had another image from Amboss, kind of doing the Amboss thing, right? So what they do in Amboss images is they kind of highlight things for you, right? And this kind of highlighting is especially helpful when it comes to looking at histological images like this and looking at x-rays. They're going to be great when we get to respiratory. So here they've done a couple things. There's these white arrowheads pointing at something. There's this blue colored stuff here, and then this portion here that they've outlined, right? As well as this black arrow, and they're showing you the thickness here. Right, so those are all the things you want to pay attention to. Now let's actually read about what they're talking about. So let me move this here so we can look at it while I read it. So the ovary is completely surrounded by cubic to columnar epithelium. Right, that's your ovary. Cubic to columnar epithelium, peritoneal epithelium, which is the black arrow. Right, so this is showing you the ovary. All right, so obviously, how are you supposed to figure that out? How would you know if someone gave you something like this? How would you know that we're looking at the ovaries? Because notice that we just said earlier that it's all simple cuboidal epithelium, but there will be some levels of columnar epithelium too sometimes, or cuboidal epithelium. The difference between cuboidal and columnar is not that vast. It's just a cuboidal cell that became a little taller, and that usually means that this portion has not erupted recently. Right? If this portion had erupted, it would be replaced by cuboidal cells at first. Right? But how would you truly know that this is the ovary? And the reason you would know is because you're seeing follicles inside. And that's what they're highlighting here. Underneath is the tunica albuginea, which is the black line. Right? So this is your tunica albuginea right here. A thin layer of connective tissue. Beneath is the cortex ovary, which consists of spinocellular connective tissue in which the numerous ovarian follicles and their distinct stages of development are embedded. Most of them are primordial follicles, which is overlaid in green. And these are primordial follicles. In dictyotin, a dormant stage, right? You don't really need to know what dictyotin is. I looked it up. It wasn't that significant. You're definitely not going to see that word on your step one. In the two marked primordial follicles, which are these two right here, condensed chromosomes are seen as basophile lumps, which is typical for this state, right? So you can see this condensed chromosome here and condensed chromosomes up there. There is a primary follicle, which is the dashed outline, this one over here. Okay, this obviously looks much different compared to these primordial follicles, clearly distinguishable by the single layer of cubic epithelial cells. On the lower edge are luteinized theca cells, which are showing you the white arrowheads. Those are the hardest ones to really tell, and those are presumable parts of the corpus luteum, which is not pictured. All right, so corpus luteum didn't fit in this image. But it's a pretty good picture to really learn how you would know if you're looking at a slide of the ovaries, and you would look for follicles. Once you see follicles, you know better that you're definitely in the ovaries. This image here is showing you the squamocolumnar junction, right? This is very similar to what we saw in GIT, right? Where in GIT, because of something like Barrett esophagus, you can have a change in epithelial let me find it real quick, in epithelial structure, right? So it's easier in pathology. Let's take a look at the metaplasia stuff right here, right? Barrett esophagus. And so it's a replacement of the stratified squamous epithelium with columnar epithelium, right? And this was the squamocolumnar junction. Squamocolumnar junction. So same thing again, right? We're having a different squamocolumnar junction over here. And that's why this picture actually looks very much just like the picture you would see in Barrett esophagus as well, until you zoom in and look at it more closely. Now, the next thing is your male reproductive anatomy, right? So we're done with looking at all the female reproductive anatomy. Now we have male reproductive anatomy, which encompasses many things. First thing they're showing you here is all that green stuff, which is the entire apparatus necessary for ejaculation, right? Ejaculation of successfully well done sperm. And that's not really that easy, right? A lot of things have to be mixed into it. It has to be built correctly. Otherwise, that sperm can often be just very non-functional. As well as arterial blood supply and the entire nervous plexuses, right? Which I've added here. You do need to know all of that. In the book itself, the first thing they're telling you is the 7-up mnemonic, which is the pathway of sperm during ejaculation, right? So you have your seminiferous tubules, right? All these little seminiferous tubules within the testes. Then you have your epididymis, right? Which is this, after it comes out, all of this stuff, right? You have your tail of the epididymis. So all of this stuff eventually leads to the epididymis. Right? You can see the pathway it's taking is very convoluted, right? So most times a sperm is actually already here. It's just ready, waiting for ejaculation to be triggered. Then it enters the vas deferens, right? After the vas deferens, it can now go into the ejaculatory ducts, and then the N doesn't really stand for anything, so it's just nothing. From the ejaculatory ducts, it will eventually reach the urethra and then the penis, and then that's it. Right now, this entire act of ejaculation and sex in general is a very high-yield topic, often being tested. So the next page talks more about it, and then I'll come back to look at this. So the next page, they go into urethral injury, and then of course the autonomic innervation of male sexual response. And there's a bunch of things you need to know about the male sexual response and the whole anatomy over here too. But before we do any of that, let's actually read what's in the book, and then I'll go revise the stuff I've added in. So, of course, you saw the urethra was a big part of this, right? Urethra is the big part of this. If you have urethral injury, you will not be able to ejaculate. Urethral injury occurs almost exclusively in men. The urethra of a female is very small, and it doesn't really get injured much. Suspect if blood is seen at the urethral meatus. Urethral catheterization is relatively contraindicated, right? You would not want to catheterize a patient in the urethra if they have urethral injury, because it's just going to cause more bleeding. So now both of these images are colored to show you where the blood would be, right? And the blood is obviously being shown in red here. So you can have an anterior urethral injury or a posterior urethral injury. The anterior one is a damage to the bulbar or spongy urethra, this soft portion over here. That's perforation of the spongy urethra, rupture of Buck's fascia, right? And you can see because of that, because it's this soft portion all the way out here, blood is now in the scrotum, right? As well as engorging the rest of the penis, right? But it's not gonna be engorging it for an erection. It's just gonna be filling it up, and the skin is just gonna plop up. So it's gonna look almost edematous, right? The blood accumulates in the scrotum. If Buck fascia is torn, urine escapes into the perineal space, and that's the yellow stuff they're showing, right? Even urine is escaping, and this patient is going to have extreme difficulty and pain and irritation in trying to urinate, which can also, if the urine is going into the wrong places, this predisposes the patient to many kinds of infections. So presentation is going to be blood at the urethral meatus and a scrotal hematoma, just full of blood, right? If blood is in the scrotum, it's a giveaway for anterior urethral injury. And that's really easy to remember because this is all the anterior part of this picture, right? The anterior part. This is the posterior part. So how do you get that? So if you have a membranous urethra injury, right, all the way in here, the membranous urethra is injured, usually due to a pelvic fracture, then now urine leaks into the retropubic space, right? Retropubic space. So all of this blood and urine is right here, right under the prostate. You see, the prostate is a nice protective body that kind of holds the urethra as it's coming through. Between the prostate and entry into the penis, there's this little open free flow space where the urethra is just, you know, a tube going through. Nothing's holding the tube. That's where it's ripped, right? It's a torn intermediate part of the urethra, and you can see just urine and blood is all just leaking right here, and that's not good at all. The patient won't even have any urine coming out, but of course their scrotum is going to be normal, right? No hematoma here. So this is just going to be blood at the urethral meatus and the high riding prostate. The prostate, because this connection has been severe, the prostate moves up, and you might not be able to do a digital rectal exam. You can see how low the prostate is here. Right, this is a very low prostate that if you do a digital rectal exam, you can palpate it. Now the prostate is much higher. It was here before within this dashed line that they've made. Now it's moved up because it disconnected from the place the urethra was in, right? So the whole time the urethra is nicely held, right? Like this area is normal here. The urethra is nicely held as it comes down and goes here, right? But here it's been severed, so now there's no connection anymore. Now, how are these things going to present in questions? So here's one right here. A 45-year-old man is brought to the emergency department after a motor vehicle accident. He is unable to void and complains of a full bladder sensation, right? So he's unable to pee. Foley catheter replacement is attempted, and remember that's contraindicated. But the procedure is aborted once resistance is encountered and the patient begins complaining of pain. Right, so that's a huge giveaway that you did something you probably shouldn't have. A CT of his chest, abdomen, and pelvis shows a left hemothorax and pelvic fracture. He is most likely to have injury involving at which portion of the urogenital tract? And the answer was the membranous urethra. There were a couple things giving it away now. You know, a couple things giving away the membranous urethra. First of all, they told you that he feels his bladder is full. Right, and here the bladder is truly very full because it can't go anywhere. It really can't exit well at all. Here the bladder might be a little full, but it's still able to exit, and it's really just going to fill up your scrotum. Right, you can see urine is even at the top, right, and at the bottom here. But here the urine can't go anywhere. It's not really going to fill up this area. Blood is going to fill it up before urine can. The urine is just going to be stuck in the bladder. Also, the bladder kind of moved up higher, so he really feels like his bladder is full. Right. On top of that, the main giveaway was the fact that they told you he had a pelvic fracture. Right? The pelvic fracture is a giveaway for membranous urethral injury too. That's deeper inside. If a patient came in with a perineal straddle injury, such as from falling on the bicycle crossbar or the top of a fence, right, where both legs just straight up fall like this on something, that's when you can injure this area down here, right, the anterior urethra. And if you injure the anterior urethra, then this patient would present complaining of very full scrotum, right? And a physical exam would show a hematoma in the scrotum and blood engorging the penis. Okay, so very different presentations, very important to remember these. And of course, if you have urethral injury, that pretty much messes up the U of 7-up. What else do you need to know? The autonomic innervation of male sexual response. This has been a question on every single NBME. They pick on a different part of it every single time, but the main thing is you have to remember all three parts have to be working. Everything has to be working for ejaculation to be successful. So point, squeeze, and shoot is a really nice mnemonic. Works perfectly for remembering it. Erection is parasympathetic, right? Obviously, it's not going to be sympathetic. Sympathetic is fight or flight, and you're not fighting someone during sex. So erection is parasympathetic nervous system. Pelvic splanchnic nerves of S2 to S4 are the ones that are truly responsible, and this is usually the answer choice on NBME. They don't even put pelvic splanchnic. They'll just put like S2 to S4, and that's what you pick for erection. That's the parasympathetic part. NO, nitrogen monoxide, increases cyclic GMP, which causes more smooth muscle relaxation and vasodilation to help have an erection. If a patient is taking something like norepinephrine, though, that's going to cause smooth muscle contraction and is anti-erectile. Right, so that was the erection part. Now emission is sympathetic, right? Because that's kind of why the other words squeeze and shoot kind of work pretty well. Pointing is not really, like a physical fight kind of thing, but squeezing someone or squeezing anything is a little more aggressive, right? So emission is sympathetic. Okay, and point, squeeze, and shoot also, the letters stand for the things right here. Emission is sympathetic, and that uses the hypogastric nerve from T11 to L2. Again, this can be an answer choice, so you have to know it. Right? And then the last thing, expulsion, that requires your pudendal nerve. It's a somatic thing. Okay, so if any of these are injured, a patient will have difficulty uh, having sex correctly. A male patient will have difficulty having sex correctly. Now, how can these things get injured? So let's take a look at some of these questions now, right? Up here, I have a U-roll picture showing you the hypogastric nerves, right? All the hypogastric nerves, everything from T1 to L2, right? And you can see this one was T11 to L2, so that's encompassed by it, right? Everything here is going to come down. These are all the things. These are hypogastric nerves. Here, down here is your pelvic splanchnic one. Right, that's the other guy that was pretty critical. And then all the way down here is your pudendal nerve. All three of these guys were very critical for being able to have sex correctly. Okay, and this one, the inferior hypogastric plexus, you can see this nerve actually goes into the cavernous sinus, whereas the pudendal nerve comes from under. All right, inferior hypogastric nerve was very important for the emission stuff. Right, sympathetic nervous system, hypogastric nerve. So how do you get questions on this? All right, so let's take a look at what you need to know. This URL question kind of tests you on the prostatic plexus, which is down here, the prostatic plexus. A 62-year-old man comes to the office due to an elevated PSA level on a screening test. When asked about genitourinary symptoms, the patient says it often takes a bit of time before my urine starts flowing, but he has no other problems. Abdominal and external genital exam are unremarkable. Digital rectal exam reveals a hard prostate with nodules. A biopsy confirms adenocarcinoma and the patient undergoes a radical prostatectomy. During the surgery, the nerves within the fascia surrounding the gland are inadvertently injured. And this is a straight up anatomy question. If you don't remember what's in that area, you're not going to get it right. What is the most likely consequence of the nerve injury? Now, the picture on the left came with this question's explanation, and the answer was erectile dysfunction. The prostatic plexus lies within the fascia of the prostate and originates from the inferior hypogastric plexus. Right, so this inferior hypogastric plexus, right, which is all the hypogastric stuff here, eventually gives you your prostatic plexus, which you can see right here. Right, and that's the prostate back there. Right, so let me make this a little bigger. Right, so you can see the prostatic plexus is all around the prostate. Right, this came from your inferior hypogastric plexus. The lesser and greater cavernous nerves arise from the prostatic plexus and pass beneath the pubic arch to innervate the corpora cavernosa of the penis and urethra. The cavernous nerves carry postganglionic parasympathetic fibers that facilitate penile erection, right? PSS, right? So the point part, which requires your pelvic splanchnic nerves, is all coming together, right? Everything's kind of coming together. You see your pelvic splanchnic nerves right here, going into the inferior hypogastric plexus, which then goes into the prostatic plexus. So if you're having prostate surgery and some of these nerves get injured, boom, you lose the ability to use your pelvic splanchnic, your inferior hypogastric, all of that. So now this patient is going to have difficulty with erection. Prostatectomy or injury to the prostatic plexus can cause erectile dysfunction, so surgeons attempt to preserve the integrity of the prostatic fascial shell during surgery. And thankfully, the nerves are within the shell, not in the prostate itself, but it's very difficult, depending on the patient's body habitus and how bad the adenocarcinoma is, to actually preserve that shell. Branches of the pudendal nerve, the other answer choice that this question also had, you can see the pudendal nerve is much more external, right? This is out here. It's not inside this plexus. It's out here. Branches of the pudendal nerve innervate the external urethral and anal sphincters. Pudendal injury can lead to fecal incontinence, decreased penile sensation, or external urethral sphincter paralysis. The cremasteric reflex is elicited by lightly stroking the medial thigh, which causes contraction of the cremaster muscle to pull up the ipsilateral testes. This reflex is also mediated by the genitofemoral nerve of L1 to L2 and may be injured with testicular torsion or L1-L2 spinal injury. Right? These are all the other answer choices: pudendal nerve, genitofemoral, etc., etc. Those nerves are very well nicely discussed in musculoskeletal. When you do the lower limb anatomy, those nerves are there too. And if we go back and take a look at it real quick, and it's always nice to revise, so this would be a good time to go back and look at those nerves since we're talking about it. Lower limb anatomy, with the nerves, you can see, right, iliohypogastric, genitofemoral, and you see the genitofemoral stuff. This image shows you how a lot of it is relevant for male anatomy, right? In this image, the genital branch and the femoral branch of the genitofemoral stuff is going on to the scrotum, right? So genitofemoral nerve, they tell you here, right, the, where is it? Cremaster, right? So it's part of the cremasteric reflex. Okay, if it's injured, you get an absent cremasteric reflex. And it can get injured. There was a very interesting question in NBME, which is why I got this image. The genitofemoral nerve, look at the path it's taking. Right? So because of the path it's taking, patients with inguinal hernias, when you do repair or surgery for the inguinal hernia, you can actually end up damaging the genitofemoral nerve. And the genitofemoral nerve has many little branches, but this blue portion is the one that's responsible for the cremasteric reflex. It's a very important nerve to make sure you know. Other than that, you have your iliohypogastric and ilioinguinal nerves, which are far outside. Okay, so those are more cutaneous. And you can see a sensory for the suprapubic region, motor for some muscles, the abdominis muscles, but not like the genitofemoral, which is a lot more deep. All right, it's a sensory for the scrotum. Other than that, of course, make sure if you're already on this page, revise the peroneal and tibial. Make sure you remember the ped and tip. Right? Those are good mnemonics. And then, of course, revise this thing real quick to make sure you don't fuck up this question. Now, pudendal nerve is down here too. Right? And that one you can see in females, you actually use the ischial spine to go ahead and anesthetize the pudendal nerve. Right? Can be blocked with local anesthetic during childbirth. And when you block it, this is actually the reason why many women during delivery can actually end up passing feces too, right? Because they have fecal incontinence. So during delivery, most times women don't eat, right? If they're pregnant, they're on their day to deliver, you don't really give them much food because fecal incontinence does occur with pudendal nerve anesthetization. Right? So make sure you go back and review all this anatomy stuff today. After this, if you're studying with this playlist live, I always tell you guys a good day to review things because it's always important to. At this time, it's very important to go back and review those nerves because those nerves are clearly tied here as well. The last thing is knowing the arteries, right? Arteries and veins. So the arteries, you see the internal pudendal artery up here? That's one of the main ones. The internal pudendal artery is one of the main ones. It gives the artery on the top, as well as the deeper arteries, the cavernous, bulbourethral, circumflex artery, and dorsal artery. The dorsal one being at the bottom, right? All of these are very important arteries to remember. The veins, not so much per se, but just keep in mind that the deep artery, right? The deep artery, which is not in this image, the deep artery of the penis is the terminal branch of the internal pudendal and supplies the corpus cavernosum. Right, so there was a weird question about how Viagra works, what artery would be filling up with blood, and it was the deep artery. And when we get to pharmacology, here, wait, not this one, reproductive pharmacology. Let me see, yeah, right here. Right, so when we get to pharmacology, this phosphodiesterase type 5 inhibitors with sildenafil and all these, I put the note here as well, right? So you have to remember the deep artery. The deep artery is very important. And it's usually not in most images, right? Even this image you see, it's not necessarily labeled. It's a dorsal artery over here at the top, anterior branch, a bunch of other stuff. The deep artery isn't necessarily labeled in this image either. I couldn't really find a good picture with it, but it was part of NBME answer choice. And it is correct according to Wikipedia too. It makes sense. And always, it's nice to remember this too. It's easier to remember because this deep, like the penis goes deep, so deep artery. And that was the same mnemonic we used to memorize the lymphatic stuff too, right? Glans penis, deep inguinal nodes, and that's the lymphatic drainage. So not so bad. Other than that, just make sure that if you ever get a question on any of this stuff, you come back and look at this, right? Come back and look at this URL picture, find arterial and venous drainage images, and of course the lymphatic image. All of this is in one place now. Down here's a couple more things about the same stuff, so let's take a look at what's happening. This one is actually related to what we looked at yesterday. So this is a USMLE RX question about the female female anatomy. So it says a 57-year-old woman is scheduled for elective hysterectomy, severing which of the following structures during surgery would most severely disrupt blood flow to the ipsilateral ovary, right? So which of these can get injured and mess up the ovaries? Well, if you're going to mess up the ovaries, you have to mess up the ovarian artery and vein. And ovarian artery, those vessels are in the suspensory ligament, right? This was something that we looked at very heavily yesterday. These first two guys are very high yield. My suspensory ligament is also called infundibulopelvic ligament. So I just call it the infundibulosuspensory ligament. And the cardinal transverse ligament, right? Because this has two names also, cardinal as well as transverse cervical ligament. So just combine the names the best you can so you can remember all the names. If you're going to be messing up ovaries, then it's the suspensory, the infundibulosuspensory ligament. If you're messing up the uterine stuff, that's going to be the cardinal transverse ligament. That's really all that was significant in terms of blood supply. Those are the only two. And down here I wrote it, like if you're doing an oophorectomy, you have to, right? You have to ligate the suspensory ligament. You have to ligate it because otherwise the patient's going to bleed out. And if you're doing a hysterectomy, you have to ligate the cardinal transverse ligament. Otherwise the patient's going to bleed out. Right? But at any time, you can actually end up damaging the other ligament as well. So let's take a look at this other question from UWorld. So this is also related to male anatomy. No, this is female actually, but similar blood vessel stuff. So 27-year-old woman, G1P0 with gestational diabetes mellitus comes to the hospital at 38 weeks gestation for evaluation of abdominal pain. She's scheduled for an elective C-section at 39 weeks as a recent ultrasound revealed that the estimated fetal weight is super high, 11 pounds. Examination reveals that the patient is in active labor and the fetus is in breech presentation. An urgent C-section is performed. During surgery, the rectus abdominis muscle is split vertically, but space appears to be limited. In anticipation of a large baby, a decision is made to transect the rectus abdominis. If incised laterally, what structure is at greatest risk of injury, right? So now this picture here is kind of showing you, right? This is the rectus abdominis muscle. It's been cut just to show you the blood vessels behind it. And the only blood vessel behind it is your inferior epigastric artery. The inferior epigastric artery is extremely high yield. UWorld, when I was studying, had a weird question where they gave you an angiogram and it shows you that there was only one blood vessel that comes out of your iliac artery and goes up. And usually most blood vessels are, either they're going to go laterally or they go down. This one is the only blood vessel that's very significant for coming out and going up. Okay, and that just off of that angiogram, you had to pick. The answer choice was inferior epigastric. Inferior epigastric artery gets tested in many weird ways just because they want you to know it's there and it's pretty significant, and it is a branch of your the iliac stuff, right? Then it becomes femoral artery. So you have to make sure you know that. Okay, and that's all this question was really about. There was nothing else to worry about. Very surreal question too. I mean, if this is happening in America, a woman with diabetes and is pregnant usually gets managed pretty well. But anything can happen. And then I have a couple more notes about the anatomy in general. But again, as I said, like this portion of reproductive anatomy is a great time to go back and study musculoskeletal anatomy, because you can clearly see there's a very strong tie between the muscles, arteries, and nerves that you learned in musculoskeletal anatomy. Now, the rest of this section, right, starts delving into more of the male stuff, right? So this is the last thing, your seminiferous tubules, right? The stuff we just looked at. And we already saw most of the female stuff. We saw how an egg ultimately became a baby, but we didn't really study about oogenesis stuff. But here they're going to give us a small introduction to spermatogonia. Okay, small introduction and a nice histological image. So let's take a look at what's happening. Spermatogonia are there to maintain germ cell pool and produce primary spermatocytes. What do? They line the seminiferous tubules, and you can see that here. Spermatogonia, right? They're the ones that are outside, far outside. They become a little more mature as they go towards the center. That's the way this works. So you can see in this cartoon image, you have your spermatogonium, the biggest cells with the biggest nucleus outside. And as they're going more towards the center, they're becoming almost completely ready sperm cells. Okay. Sertoli cells and Leydig cells were something we slightly touched on during the early embryology section in reproductive. actually the end of reproductive embryology, where they talked about, the indifferent gonads becoming either male or female gonads. The female gonads were the default setup. The male gonads would occur if you're an XY patient or an XY human, and the Y chromosome releases testes determining factor, which means now you've made testes, right? And the testes have two sets of groups that release cells, Sertoli cells and Leydig cells. The Sertoli cells were the ones that produce MIF, right? And this went and stopped the production or the development of internal female genitals, right? Internal female development. It stops that. And then the Leydig cells were the ones that made testosterone, which went ahead and made the penis and all of that. And of course, you had your DHT, which converted testosterone into thiol reductase, which converted testosterone to dihydrotestosterone, DHT, and that finished up male development. So now, lacking alpha, thiol reductase wasn't that big of a deal, and we saw this right here. So let me just go back to it real quick. This page, right? So you see how testes are making testosterone, and that's going to go here and upregulate the formation of male internal genitalia, whereas Sertoli cells have MIF to stop the development of female internal genitalia. Okay, so that's very significant. That's very significant. So if you're lacking testosterone, you might not do this at all, and that's going to suck, right? So you're going to be missing an ejaculatory duct, ductus deferens, all of that stuff. Internal male genitalia. The 5-alpha reductase converts testosterone to DHT to make the male external genitalia, penis, scrotum, and prostate. Right? If you get questions on where the prostate came from, that's DHT related. And you can remember that because finasteride is a treatment for BPH, right? Because it actually inhibits 5-alpha reductase. And then, of course, if the bigger issue was if you don't have Sertoli cells or you don't make MIF. If you don't make MIF, you're going to be a male that also has internal female genitalia, fallopian tubes, uterus, proximal vagina, and all of that is not going to work out too well. Right? That's going to suck. So other than that, they tell you a couple more things here. Now, Sertoli cells also secrete inhibin B, and inhibin B inhibits FSH release. All right? Secretes also androgen binding protein, which allows androgens to be concentrated within the local area. Tight junctions between adjacent Sertoli cells form the blood-testes barrier, which isolates gametes from autoimmune attack because your gametes don't necessarily look like your own body cells. Support and nourish developing spermatozoa, regulate spermatogenesis, and these guys, the Sertoli cells, are the reason our testes are outside our body. Sertoli cells are very temperature sensitive. Right? So if you have high temperatures, you get decreased sperm production and decreased inhibin B. Right? So in a patient who might have a varicocele or a patient with cryptorchidism where their testes didn't descend, temperatures are going to be high, and that increases the chances of them having the risk of being infertile. Right? Other than that, these are the basic things you do need to know about Sertoli cells. And generally speaking, Sertoli cells are the nurses of your sperm. Right? They're just there as a support system, and they inhibit FSH. Right? Whereas ladies love testosterone, so again, ladies dig testosterone because Leydig cells make testosterone in the presence of LH. Okay, so if you're not making enough testosterone, it might be because you don't have LH. And if you don't make testosterone, as we just saw, you won't be able to make the internal male organs. So that's going to suck. No epididymis, none of that. And of course, without testosterone, you can't have DHT either. So a lack of LH can be in a question, and then the male won't develop much at all. And lack of FSH can be a question. Any of these things can be a question. And if you're missing things, you need to know what the end result is going to be. Okay. So here is kind of a connection with endocrine again, because remember in endocrine, we didn't necessarily talk too much about the sexual hormones. Endocrine chapter discussed all the other hormones, ADH, TSH, all of those things, but not so much about LH, FSH, and then testosterone and estrogen. Not that much at all, except for in the congenital adrenal hyperplasias section. So hypothalamus releases gonadotropin-releasing hormone, goes to the anterior pituitary, which then makes LH and FSH. FSH goes inside, right, and works with the nurses, the Sertoli cells, and the Sertoli cells are making, you see there's like a negative feedback, making inhibin B to stop the release of more FSH if they don't need it. Whereas LH, you see, goes out here to the Leydig cell and tells Leydig cells to make more testosterone. So it's nice, it's easy to remember because LH starts with an L, and Leydig cells have an L. Sertoli cells have an S, and that's with Sertoli cells. sorry, FSH has an S, my bad. Sertoli cells has an S, and that's with FSH, okay? So there's no space for confusion there. They did a nice job with the color coding thing here to help you remember that. And if you get a patient who they tell you they're not making enough LH, that means they're not going to make enough testosterone, and that's going to mess up all their development. If you have a patient with FSH issues, that's something that's being wrong with Sertoli cells. You know, and based off of that, read the rest of the question, and then you're able to finish that, right, and solve it. So now, that's really it for that. This stuff is going to actually get tested a lot more later on, but did we? No, we actually sort of already saw most of it. This is just a little bit more anatomy regarding where the ureters are. Right, so you can see here, this is actually showing you kind of the difference between the female and male stuff. This is the last anatomy thing. It's not really in first aid, so I made sure I inserted it, because this does get discussed a little more, but not so much in depth per se. So let's just take a look at it, and then we'll be done with reproductive anatomy. So there's a mnemonic, right? Water flows over the iliacs and under the bridge, right? The uterine artery or vas deferens. This stuff was looked at a little bit earlier, I think in renal, but not so much here. So there's a question right here. A 14-year-old boy arrives in the emergency department after the sudden onset of excruciating left scrotal pain, which is significant, right? Because the left gonadal vein goes to the left renal vein, right? So that blood flow is a little messed up. On physical exam, elevation of the left scrotum failed to alleviate the pain, and stroking the inner thigh failed to elicit scrotal elevation, which is related to your genitofemoral nerve. Doppler ultrasonography shows decreased blood flow through a specific artery in the spermatic cord. Which of the following structures is located inferiorly to this artery before this artery enters the spermatic cord? Right, and this is literally a direct question about water flows over the iliacs and under the bridge, which is the uterine artery or the vas deferens, right? So we're talking about a male, so we're going to be on this side, right? This is the male side over here. You have the vas deferens going over the ureter, right? But the artery, right? Remember, water flows over the iliacs. So which of the following structures is under the, and they're looking at the artery, right? The spermatic artery. So what's under that artery? It's just going to be the ureter. And that's true in both sides. Okay, that's true in both sides. The ureter goes over the iliacs, okay, and under the artery. So if they're looking at right here in this question, they're like Doppler ultrasonography shows decreased blood flow through a certain artery. What structure is located under this artery? That's going to be your ureter. Okay, so be ready for that. The vas deferens, in males, the vas deferens is on top of the ureter, as you can see here. And in females, the uterine artery is on top of the ureter. Okay, so depending on what gender you're working with and what the question scenario is about, you have to be ready with that. Okay, this is just a stupid anatomy thing that you can get simple questions on. Don't mess it up. Okay, so that's about it for reproductive anatomy. It's a pretty dense section compared to the other chapters. Embryology and anatomy here is really closely tied to a lot of the other stuff we looked at earlier, so it's a good time to revise any of that too. And then in the next video, we'll move on to reproductive physiology.